On behalf of yeah, on behalf of Bombay Psychiatric Society and IPS Vadodara, we welcome you here once again to yet another session of Brain on Wednesdays. And the topic today is microglial dysfunction in psychiatric disorders by Dr. Nachiket Desai. And to chair this session, we have Dr. Ashutosh Shah from Mumbai. He is a consultant psychiatrist at the Sir H.N. Reliance Foundation Hospital. He has an experience of 25 years in clinical practice. He is also a very keen interest in research and has almost 14 publications. He has special interest in mood disorders, schizophrenias, and dementias. And as we all know, he is into biological psychiatry and reads a lot of latest research in biological psychiatry. So I welcome Dr. Ashutosh Shah, chairperson, and the speaker, Dr. Nachiket Desai. Over to you, Dr. Ashutosh, for introduction of Dr. Nachiket and setting the stage for the topic. Thank you.
Thank you very much, President Madam Dr. Shobha Nair, and a very good evening to all who have joined us. So today the topic with Dr. Nachiketa is going to enlighten us about is microglial involvement in psychiatric disorders. So most often we are always focused on neuronal dysfunction, but equally important are the glial cells, of which one variety is the microglia. And just to recapitulate, microglia is the only type of cell within the central nervous system which does not have an ectodermal origin. It's from the hematopoietic cell line. And to discuss more in details, I will lay over the stage to Dr. Nachiketa, who also is now a well experienced, I believe, almost close to a decade, Dr. Nachiketa, in practice.
Yes.
In Navsari, Gujarat, and is equally an avid biologically oriented psychiatrist based on what I'm learning from him in the common WhatsApp groups. And the stage is all yours, Dr. Nachiketa. We would like to learn from you now. Thank you.
Thank you, sir. I will just start my screen share. So I welcome you all on this eve of World Suicide Prevention Day. The microglia, as sir has rightly said, is a type of cell, possibly only type of cell that is not originally from CNS, from periphery myeloid cell, the brain, and yet it practically and all. Previously we had a session.
Dr. Nachiketa, your audio is not very clear. It's breaking up.
Hello, is it better now?
Yes, this is better.
Yeah. So previously we had a session on microglial dysfunction in neurodevelopmental disorders. There we saw that microglia have different types. They don't act alone. They interact with other cells, and they also play a part in neurovascular coupling, which communicates with periphery. Classically, there were two types, M1 and M2, which were defined by different functions as well as different markers. M1 is more of pro-inflammatory, M2 is more of anti-inflammatory and repair-related functions, wound healing, etc. But over time, we have seen that there are more than two types. Via single nucleotide RNA sequencing and single cell RNA sequencing, we came across various types like white matter associated, disease associated, lipid droplet accumulating, or microglial neurodegenerative phenotypes, which are defined by various markers shown in picture. And the types go even beyond this. Nowadays, it is almost like immunophenotyping. There are multiple variants, some disease-specific variants also. Historically, they seem to have certain roles like pathogen removal, response to disease or injury. But over time, we have found that they have important role in synaptic plasticity and neuroplasticity and other functions also. Zhu et al. Has summed up these functions. Microglia play a role in brain development, neurogenesis, immune surveillance function, angiogenesis function, maintaining cerebral blood flow, It also plays a role in blood-brain barrier permeability via food processes of astrocytes, synaptic plasticity in terms of synapse protection or pruning. It also plays part in debris clearance in form of phagocytosis and efferocytosis. It also interacts with astrocytes mainly, but all the CNS cells. It also has a specific function called durotaxis, which will become relevant later on. In short, what it means is microglia move towards Streifer area and piezo1 and certain receptors and other things get involved in that. This is specifically relevant in terms of the A beta plaques and fibrils, which are stiffer, and then this go and then get involved into phagocytosis and efferocytosis of those debris materials. If this becomes problematic or dysfunctional, then we see its role in neurodegenerative conditions later on. The main interaction that is important is with astrocytes because they work as a tag team. Activated microglia activate astrocyte. Astrocyte in turn again activate few more microglia. Then there is CD200 which converts activated microglia to again resting state. The activated astrocytes also contribute to extracellular vesicle release, that efferocytosis part, and this astrocyte also play an important part in chemotaxis towards site of injury, where they can affect the microenvironment via chemokines and other functions. And then different functions are affected differently and get involved in different diseases. Here are some examples. At different stages of life, these functions are affected differentially. For example, angiogenesis is the function or process that happens throughout the life, whereas neurogenesis and migration mainly occurs in antenatal and early postnatal period. At each stage, different factors can affect these processes differently and lead to different symptoms, which we call as DSM or ICD disorders. How does that happen? Let's compare a normal functioning. These are normal microglia working in maintenance and stabilization and looking after of the neurons for normal functioning of brain. They can either become dysfunctional microglia at early stage and destabilize the system, which later on produce symptoms. These are mostly seen in early neonatal period, or they can be primed microglia, which are not totally dysfunctional at this level, but at later stage there is another hit, and then it leads to destabilization and symptoms which occurs usually around puberty or young adulthood. Or these microglia, they are now becoming senescent or aging rapidly, losing that M1 M2 boundary. The dysfunctions ultimately end up presenting as neurodegenerative or late adulthood conditions. And across this, they can present as microglial density or phenotypic changes or myelination related changes or altered communication between microglia and other cells, which are found in different conditions. And sometimes there are sexual differences also, which is related to sexual dimorphism of microglia. That is how we see female bias in depression and sees ASD or ADSD bias in male. Now, coming to today's main discussion, disorder-wise details. I would like to mention a few things here. While preparing for the today's topic, I came across few observations. One thing was that disorders as we define in DSM and ICD are more of symptoms, and there is huge overlap in the findings across disorders. And then we can see that these findings are not just limited to psychiatric manifestations, but they have close ties with immune function and other systems also. That is how we can look at clustering of non-communicable diseases in our disorders. For example, a person with schizophrenia or autism is more prone to immune dysfunctions also. We will focus on each disorder and have some representative findings because a comprehensive session would go on too long. Majority of research has either centered on neurodevelopmental disorders or on neurodegenerative disorders or depressions, but There is finding for almost each and every condition we see in psychiatry. And again, to reiterate, the findings are overlapping. And how does that happen? So any kind of physiological stress leads to microglial response, and then there would be a repair phase. So if the inflammation is impaired, there can be pathology. If the repaired part is impaired, there can again be pathology of different types. And many a times there is combination of these things. And depending on that, there are therapeutic targets for that. There can be anti-inflammatory treatment. There can be treatment targeting inhibition systems. There can be pro-neurogenesis function related treatment approaches. This not only includes medicines, but brain stimulation also has some role in all these contexts. And that's how the pathology that affects our various disorders are targeted by different interventions focusing on microglial dysfunction. One of the common area that is in research is perinatal brain injury. Why this is important for psychiatry? One major area is neurodevelopmental disorders and intellectual disability. There are many CNS conditions that are presenting a syndrome of psychiatric and neurological disorders. Many of them are explained through this perinatal brain injury. Various pathways are involved, for example, PPAR, gamma pathway, WNT pathway. There is PNSD95, microRNA related changes also. All this, but in a nutshell, all this lead to microglial activation and M1 phenotype in older classifications. Another finding was PSD95 mutation. These lead to abnormal microglia, which present as autism, epilepsy, or intellectual disabilities, and this is by and large affecting synaptic health or synaptic stability, and that is why they are also called synaptopathies or neuronal synaptic disorders. The pathophysiology is whenever there is hypoxic ischemic insult and there is pro-inflammatory response phase, first step, then there is anti-inflammatory or reparative phase, and at a later stage there is tertiary phase. All these phases lead to some or the other changes, and over a period of time it can either lead to degraded neurodevelopmental trajectory or certain dysfunction. If they are severe enough, they can manifest as childhood or infantile disorders itself. So in a nutshell, various kinds of damages lead to inflammation. Inflammation lead to M1 or activated microglia, which activate astrocyte, communicate with other cells. And this is the neuroinflammatory hypothesis of many of the conditions we see clinically. And over a period of time, it leads to maldevelopment that presents as overlap with common conditions we see. For example, autism spectrum disorders, multiple sclerosis, even neurodegenerative conditions like PD or Alzheimer's disease. They also share some mechanism with perinatal brain injuries. Traumatic brain injuries also share this. By and large, common finding is this is, I would say, final common pathway. Microglial activation and converting it to pro-inflammatory phenotypes, which leads to downstream effects in form of reactive oxygen species and other functions. Now, if the activated microglia or pro-inflammatory phenotype is overactive, then there are problems, or the reparative phase gets dysfunctional and the inflammation is not terminated as expected, then also it is a problem. Similarly, the mediation or coordination of this via communication with astrocyte, if that gets affected, then also we see problems. And so the potential therapeutic targets would target all these various findings, be it PPAR, gamma related pathways, or AMP kinase related pathways, or WNT pathways. And the candidates, many of them are very familiar. For example, diabetes medicines like pioglitazone, metformin, and our analgesics like nimesulide, which is now not that commonly available, or indomethacin, even montelukast. And then there are other experimental molecules which are under trial, and they show that these again improve microglial function and thereby help in various conditions. As the dysfunctions overlap across the disorders, the treatment modality or intervention tried also overlap across disorders. Coming to autism, again, prolonged microglial activation leads to neuronal cell death. There is impaired synaptic pruning, which leads to inefficient excitatory synapses. In preclinical models, there is chemokine 3 receptor knockout mouse models which show reduced functional connectivity, and clinically it manifests as reduced sociability, increased repetitive behavior which are stereotypical or autism-like. There is disrupted microglial homeostasis, and it again leads to abnormal neuroplasticity and autistic behaviors. The key point here is, rather than neuronal pathology per se, majority of dysfunctions are centering around microglial pathology. The elevated protein synthesis in microglia rather than neurons, they affect the clinical presentation and present as social deficit, repetitive behavior, or cognitive impairment in the preclinical models as well as clinical presentations. Again, same PSD95, CXA, CR1, these genes are involved. The second hit, the way we talked in slides before, that there is a priming and then there is environmental hit. In that environmental part, there is maternal immune activation, abnormal microbiota. This involves gut-brain axis, fevers, inflammations. These lead to various myelin defects, impact synaptogenesis, and again sexual dimorphism comes into play. And this is how they present as sex bias in ASD also. In preclinical models, the loss of MACP2 has a glutamatergic excitotoxicity, but independently, there is also CXA, CR1, GFP report on mice related pathological dewiring and excessive removal of exon terminals leading to presentation of Rett syndrome. Now, this is again another term, the axonopathies. Like synapse, there can be axonopathy. Therapeutic strategies again centered on reducing that overactive microglia. There are dual active ligands, H3 are antagonists. Now this H3 are histamine 3 receptor antagonist. One of them is already known, that is pitolisant in narcolepsy. When there is less response to modafinil, people have tried targeting histaminic axis. That pitolisant is also being tried for various cognitive functions, autism-like behaviors, other microglial inhibitor. One name is very familiar, minocycline. Although we know it as antibiotic, it has a lot of upcoming role in microglial function. It can be considered microglial inhibitor, but it is more of inhibitor of pro-inflammatory stage and thereby helping in various psychiatric disorders. So the promising agents are prednisone, it has some role, anti-inflammatory action, minocycline, even N-acetylcysteine that we know as antioxidant, it has role. Oxytocin, there are many trials of oxytocin in autism. Possibly one of the action is through this management of microglial function and balance of that pro-inflammatory and anti-inflammatory functions. Schizophrenia, again, what I have seen in literature is huge overlap between autism and schizophrenia biologically, so much so that they are more of looking like spectrum rather than two separate diseases. Increased microglial density and size in gray matter of temporal and frontal region is noted. There is increased CD64 and HLA-DR expression in dorsal PFC. Ultimately, again, pro-inflammatory state. In postmortem studies, this battery of multiple pro-inflammatory markers, the module, was found overexpressed in prefrontal cortex of patients. How does that work? Neuroinflammation in fetal period affects cerebellar, insular cortex, fusiform gyral area development, and deficit in neuronal activation in amygdala, fusiform gyrus, and VLPFC ultimately lead to developmental aberrations, and the microglia mediated glutamatergic excitotoxicity or neurotoxicity is also playing role in cognitive impairment as shown here. This is very well targeted with various microglial inhibitors or GLP-1 agonists or cholinergic agonists or the 5-HT3R antagonist, the pitolisant one we saw previously. The negative and cognitive symptom part is again huge overlap with autism. Same CS3, CR1 involvement, upregulation of pro-inflammatory genes and proteins. There is higher microglial polygenic score overall, and they correlate well with greater cognitive impairment and lower grave matter volumes. The abnormal synaptic pruning is a shared pathology with autism, and abnormal immune activation possibly is the common shared pathology between autism, schizophrenia, and immune disturbances. Now, what all this does is cerebral desynchronization and disconnectivity. We can see this in functional connectomics and sometimes even in structural connectonics if the myelin defect is significant enough. Strategy is again inhibition of microglial activation, for example, minocycline. Coming to bipolar mood disorder, previous mentioned findings are already applicable to bipolar mood disorder also, but to come to disorder specific findings, CD206 has been considered a potential state marker. This is a gene or marker favoring M2 phenotype or anti-inflammatory phenotype, and it is downregulated more in mania. Now, like we see polarity index in treatment modalities, and we clinically see whether manic predominant bipolar presentation or depressive predominant bipolar presentation, the M1 M2 ratio, the pro-inflammatory to anti-inflammatory phenotype ratio, differs between manic and depressive state and can be a marker. And the genome-wide association studies, although showing huge overlap between schizophrenia, bipolar disorder, intelligence-related brain functions and pathologies, it does endorse disease-specific alteration in microglia, specifically immune responses and phagocytic functions. And this is correlated in postmortem analysis as increased levels of IL-1 beta, INOS, CD11B in frontal cortex of bipolar patients. The depression part, again, by and large, depressive phase is assessed not as a unipolar or bipolar, but pooled findings are applicable to both the condition with the exception of that CD206 and M1 M2 ratio indicative of bipolar states. The studies are done in PET or TSPO binding studies. They have variable findings because of the heterogeneity of population. Not all depression patients have same pathology. However, some studies did indicate elevated binding of TSPO in anterior cingulate cortex. Now, this ACC frequently comes up in depression and anxiety related findings. Again, the cytokine dysregulation of pro-inflammatory cytokines is there. Impaired microglial function leads to impaired neurogenesis, neuronal activity, and synaptic remodeling. This leads to poor neuronal maladaptation during stress exposure. Specifically, one symptom of anhedonia was studied in one article. It shows that HMB receptor, HMB protein activates RAGE receptors on hippocampal microglia. These microglia were already primed by chronic stress. If this happens, it leads to anhedonia. Then there is inflammatory hypothesis of depression. This pathogen host defense theory is basically almost the same thing. It wants to tell that via PAMP and DAMP pathways through toll-like receptors, microglia are activated to M1 state, and that pro-inflammatory response ultimately leads to depressive symptoms. And to study that, the Microglial activation. As we discussed before, the microglial types are not limited to M1, M2, then they went to DAM and LDAMs and MGND and other phenotypes. But over a period of time, there are even disease or rather presentation specific phenotypes. I won't call them diseases. Then there is in that line, there is this depression specific disease associated microglial phenotype, that is shortly DEPDEM phenotype. It has specific changes in downregulation of gene involved in immune response as well as phagocytic functions. And there is also decreased connectivity in prefrontal cortex, reduced spinal density, downregulation of synaptic function genes. As talked in autism and other disorders, sexual dimorphism is possibly the explanation of female preponderance in depression. Therapeutic aspect, minocycline as well as our familiar medicine fluoxetine, they have shown protective effect against microglial activation mediated neurotoxicity, and the S3R antagonist like pitolisant likely alleviate neuroinflammatory processes and improve cognitive function. They do so by shifting this balance from pro-inflammatory to anti-inflammatory phenotype, which is related to synaptic plasticity, cell survival, neurogenesis, and cognition. So this is possibly the mechanism how S3R antagonists are leveraged in psychiatric disorders, cutting across all conditions, not limited by DSM diagnosis. And primarily what they target is this cell survival and this specifically cognitive function part. So it has role in cognition, possibly role in arousal as evident by its application in narcolepsy and possibly other hypersomnias. Maybe appetitive behavior, but I am not sure. I have only come across pitolisant as used in narcolepsy or these conditions. Topic relevant to today's special day, suicide. There are specific suicide related changes in some studies. Now, if you look at the slides here, I know it is hard to see, but these black or purplish dots, these are microglia. If you look closely, they are not dot-like, but they are more like spiders or star-shaped. Here, normally there is less density of those dots. This is dorsal raphe nucleus in non-suicidal depressed patient. But the picture above, if you see there are multiple these purple or black dots. This is the increased microglial density that is seen in DLPFC, ACC again, mediodorsal thalamus and white matters of prefrontal cortex or in dorsal raphe nucleus. Now the microglial activation as noted by this density or the functional markers, it correlates with transcriptional activity in DRN in both non-suicidal and suicidal patients, but the more density is indicative of suicidal tendency because again the neuroinflammation is involved, and we clinically can correlate that when there is hyperinflammatory state, we also see early morning awakening, that 3 to 5 a.m. period. Whenever there is agitation, anxiety, inflammatory changes, there is higher risk of suicidal ideation and behavior both. Metabolically, kynurenine pathway is involved as evident by elevated quinolinic acid in ACC. TSPO binding again increases in PFC, insula. This correlates with depression severity and suicidal thoughts. This is functional neuroimaging. Previous one was also involving histopath and other findings. In anxiety and OCD, there are relatively less study compared to other conditions we saw so far, but some of the findings are HOXB8 knockout genes, mice expressed compulsive grooming. This is one of the preclinical model of OCD. In frontotemporal dementia also, if there is progranulin mutation, it presents as OCD related phenotype, and even in preclinical models of this gene knockout or mutation, there is grooming behavior, which is again a preclinical model of OCD. In case of stroke also, like TBI or perinatal brain injury, the upregulation of HDAC3 leads to downstream activation of NFK beta pathway, which ultimately leads to prostaglandin E2 release in amygdala, which again makes one prone to anxiety. So these deviations can be neurodevelopmental in nature or can develop later on in form of stroke or other insults. Similarly, in RSDS-induced microglia, threat appraisal region of brain gets upregulation of interleukin-1. This again presents as anxiety-like behaviors. Now coming to addiction. Addiction already shares a lot of findings with previously seen disorders. And there are common substrates. For example, impulsivity cuts across various disorders we see clinically, similarly compulsivity. So those findings will overlap. Still, we will try to look at some examples or demonstrative findings rather than comprehensive list of findings. In case of alcohol, increased pro-inflammatory cytokine leads to, again, neurodegenerative changes in cerebral cortex and hippocampus. One specific finding relevant to this is involvement of TLR4 receptors. This is again PAM-DAM pathway activation through TLR on microglia. This particular IBA1 related immunoreactivity and knockdown of TLR prevented death. This indicates that TLR4 may be one pathway through which we can target alcohol intake. It seems that TLR mediated activation and MCP1 related changes, especially in central amygdala or VTA, lead to increased alcohol intake, and targeting them seem to reduce the alcohol amount. So this is probably more in line of naltrexone related reduction in alcohol intake rather than the aversive mechanism or other findings of other interventions that target abstinence. And it is also seen later on in these slides here that naltrexone does target that anti-inflammatory effect via TLR. So the minocycline again has some role. Now we repeatedly see minocycline. It has variable findings. In some cases, it has more of augmentary role. In some cases, the effect size or the evidence is relatively stronger. But yes, targeting pro-inflammatory phenotype of microglia or activated microglia is one of the main mechanisms where we are trying to approach psychiatric disorders through the lens of microglial dysfunction. In opioid also, chronic exposure leads to more apoptosis of microglia. However, this is to some extent reversible by naloxone. There is also increased expression of TLR9, which leads to apoptosis of microglia. The morphine tolerance, again, if you block the release of the pro-inflammatory cytokines and prevent that microglial activation, it can actually postpone the morphine tolerance. So that is one of possible avenue of intervention. Ibudilast, which is a phosphodiesterase inhibitor, this suppresses these pro-inflammatory responses mainly through TLR4, and as we saw before, naltrexone possibly also target this. Similarly, minocycline also targets this. Both can reduce opioid withdrawal symptoms while maintaining analgesic effects. Similarly, pannexin-1 has been identified as one of the potential clinical targets. This reduces the severity of withdrawal symptoms without affecting analgesic effects. So this can be possibly one area which can be applicable to specific population where we start some treatment, or rather, let's say we can call it self-medication model of opioid dependence, where person actually wants analgesia, but the other effects and the underlying diathesis is leading to opioid dependence. In such cases, this may be a very interesting avenue where the analgesic effect is maintained, but it still prevents the opioid use disorder or dependence. In case of methamphetamine, Acutely, it can lead to neurotoxicity of dopamine nerve endings of striatum, or chronically, it can lead to decreased microglial activation in arcuate nucleus. Now, this would also have certain downstream effects, and the homeostasis or the N1 M2 balance is disturbed, and which ultimately leads to different symptoms. So the methamphetamine related altered immune function of microglia through P2XR7R signaling is one of the potential avenue of intervention. This methamphetamine related changes also induce vascular directed responses of microglia. This affects cerebral neurovascular coupling and other vascular functions, and hampers the vascular repair, which is also another pathology, and may lead to the methamphetamine related changes and clinical presentation. Again, minocycline decrease the rewarding effect of dextroamphetamine also. Same way, endomethacin also attenuated the neuroinflammatory changes, and again the ibudilast attenuated the subjective rewarding effects. So this attenuation of subjective rewarding effect is something like blocking of highs with naltrexone that we usually clinically see. In case of nicotine, there is pro-inflammatory signaling in nucleus accumbens. Again, VTA area also gets involved. Increased expression of LOX2. This produces a reactive oxygen species which potentiates withdrawal related anxiety. So this is the intersection of nicotine related findings and anxiety related findings. If somehow we can target this, we can then ultimately reduce this anxiety craving and thereby help person abstain from nicotine. However, this is not the only mechanism. Nicotine directly can induce microglial activation via nicotinergic receptors and other ways, and specifically in reward seeking areas. So this also contributes to the nicotine addiction and thus dependence or addiction cycle as we understand. This also potentiates other addictions, for example, cocaine reinforcement. However, this effect was more in adolescent rats, not in adult rats, so there is possibly an age-dependent effect. And clinically, we also see a observation that those who have started before 20 or let's say before 18, they are at more risk of getting dependent rather than those who start later in their life, for example, 25 plus. So possibly one of the mechanism is through this microglial dysfunction lens. Coming to degenerative disorders. Now this again is as big area as neurodevelopmental disorder and microglial dysfunction. So I have tried to limit it to certain important findings. Broadly speaking, in healthy state, the resilience is more functioning well, I would say. And so in childhood, there is growth function more than the inflammatory part. And so child is growing, and in adulthood, there is almost a balance. There is some pro-inflammatory changes. At the same time, there is reparative phase also, and the balance is maintained. As the age increases, the degenerative part starts taking over. And we see different functions like this CD200R. This was the receptor that would again deactivate the activated microglia or convert it from M1 to M2 phenotype. If that is decreased, there would be ongoing low grade or moderate grade inflammation, which contributes to neurodegenerative changes via reactive oxygen species, redox pathway, and all those things. So the exaggerated inflammatory cytokine production, maladaptive responses, failure to resolve neuroinflammation, these seem to be the crux of neurodegenerative changes, and it is applicable not only to microglia. Same thing happens with astrocyte also. Both become pro-inflammatory, and neuroinflammatory and neuronal death. This again, when at this point, if the cells are not able to convert or revert to anti-inflammatory state and there is ongoing neuroinflammation, there would be more debris, more damaged product. At certain point, the tipping point is reached and now cell is doomed to apoptosis. And that's how it leads to cell loss, and neuronal death, which is explained here. Classical or alternative activation leads to pro-inflammatory state, but at a later date there is tissue repair function. If this is affected in old age, there is not enough repair, but the inflammation is ongoing. So it will lead to neurotoxicity, neurodegeneration via apoptosis or excitotoxicity or low-grade immune activation. And there would be collection of debris in case of A beta. The debris are not efferocytosed effectively. They would also release pro-inflammatory chemokines, which will attract more cells. Similar thing applies to synucleinopathy, but here the protein is alpha-synuclein. Similarly, MSTT will lead to Huntington presentation. TREM2 mutation will lead to ALS presentation. And here that neurotoxic thing comes again. Wherever there is local stiff area in terms of membrane pliability and other factors, sensed by piezo 1 or rather sensed through piezo 1 by microglia. Then the microglia move to stiffer area, probably identify those fibrils and debris, then exocytose them and help cells survive by reducing cellular inflammation. But if the function is impaired, we will see ongoing neuroinflammation and ultimately neurodegeneration. Now, this is where that thing comes. The immune-mediated therapies of canemabs, lecanemab, adalimumab, all those things, they are targeting the debris. But rather than we should target this microglial dysfunction, the garbage collectors rather than targeting the garbage. And that's how these various phenotypes are observable. MGND is more relevant in multiple sclerosis. Otherwise, all the other phenotypes are also seen in different diseases like Alzheimer, Parkinson, or ALS. Now, in this disease specific, there is also a type called Alzheimer-related DEM. And then there is early Alzheimer DEM, and then there is late Alzheimer DEM. All these are being investigated. They differ via all these markers. And then there are different potential treatment options targeting different mechanisms. Not only the medicines we saw previously, that is indomethacin, minocycline, pioglitazone, but also antihypertensive like candesartan or even atomoxetine or baricitinib or even the celecoxib. All these seem to have promising results in various ongoing trials. Similarly, in case of Parkinson's disease, semaglutide, rifaximin, exenatide, clavulitazone, beta-glucose, and other agents. Now, one of the area, this pioglitazone or metformin or all these things that are preventing degenerative changes, preventing apoptotic changes, helping cell survival. This is why sometimes they are also studied or combined under the rubric of senolytics that are slowing the aging or senostatics. That is again another interesting area how we target the accelerated aging, but it again intersects with this microglial function and dysfunction thing. That is for today. Thank you. I'll stop my screen share.
Excellent, Dr. Nachiketa. So you have actually condensed a lot of information in your talk, beginning with neurodevelopmental disorders, the so-called schizophrenias, which according to you represent nothing but a spectrum of the neurodevelopmental disorders, and then bipolar disorders, mood disorders, as well as in neurodegenerative disorders. And with this, I would say the floor is open to question. You may unmute yourself if allowed, or you can type in the chat box. So while people are doing that, Dr. Nachiketa, one question would be, practically, how would we know in clinical practice when to target microglia? Because preventing an inflammatory response may not be always the best situation. So, clinically, we did see that you have highlighted several molecules which can be used. When do we use them with the specific target of microglia?
So I would first like to give a context. There is a peripheral inflammation and there is central inflammation. Microglia are primary central immune system. Because of the blood-brain barrier, peripheral cells don't directly go there. Now they communicate with periphery via those neurovascular couplings and blood-brain barrier things where peripheral chemokines cross central and all those things. So simply targeting any anti-inflammatory itself, we first have to contextualize that whether we are targeting central or peripheral inflammation. Now, sometimes we can see that clinically, elevated ESR, CRP, those non-specific things. How well those peripheral markers correlate with central inflammation, that is one question. But if at all we are seeing this in clinical context, purely clinical context, then I would say that, let's say, treatment resistant conditions where we are not seeing enough, then we can go through evidence base and try kind of an educated guess that, okay, nothing else is working, let me try this. Down the line, when these trials have enough literature base and more importantly, enough replicated findings, then they would become primarily the established treatment intervention, one of the thing. Secondly, there are certain areas, for example, narcolepsy, we have very few options. And we already know that pitolisant works there. This is newer molecule after modafinil. So there, and in case of fluoxetine in MDD, as we saw, or let's say somebody is already on minocycline and there is some literature in treatment resistant keys and treatment resistant bipolar where we see minocycline suggested as some second or third line. There we can conceptualize that, okay, this is probably the mechanism whereby this is working. So in that sense, I would logically extend it that whether if the way minocycline works centrally, and particularly let's say TRAM2 receptor. TRAM2 is a common across monocyte and macrophage, so peripheral and central both. So possibly if minocycline is working like this, then we are looking at another molecule like hydroxychloroquine that we use in rheumatoid arthritis. Another way this can apply clinically is already existing molecules. We see the effect, but we are not able to explain. Maybe there are explanations through microglial intervention. I have not touched upon memantine. I have not touched upon certain other areas. I have not gone into neurovascular coupling because, to be very honest, it was getting too comprehensive and bit confusing because you would hear same names multiple times in all disorders. And the difference is that damn thing, this is associated microglial phenotype. Now, how these are defined? These are defined more like the way we see in cancer, immunophenotyping. And then there are still ongoing studies which are targeting specific phenotypes. But for a clinician, it ultimately boils down to what tools I have and whether those tools are working through this effect or the untouched area that I have not talked about. Let's say something is affecting microglial function and blood-brain barrier permeability. There are studies on that, but I have excluded those. I have not gone into gut-brain axis because it was getting too extensive. So there are certain things that is targeting peripheral central both inflammation. There are certain things that are targeting certain central inflammation, the way we see inflammatory hypothesis of psychiatric disorders. But many of them are waiting for replication to come into clinical practice.
Okay, thank you. So what I understand is as of today, we are still to treat as usual. Only when
Yes.
it's not working, then we
In
think,
resistant cases, we can look at them and we can look at co-occurring or clustering of non-communicable diseases. That way we may have some target areas where we can reduce pill burden.
okay, fine. More question from the audience?
I can understand the way this topic is already is very underexplored. Even it was hard for me myself.
No, it's a I would say new area which is now
Opinion.
explored,
Agreed.
and the role of glial cells in general, not just microglia, in
Agreed.
various diseases of the central nervous system is also getting a
True,
new
sir.
perspective. So it's a new area. As things stand today, they may not directly translate into our clinical practice, but nonetheless, it will lay a foundation for future therapies which will come over. So maybe in the coming decade, we may see something. Today, as it stands, we may not be able to exploit this knowledge into direct clinical
It
practice.
has limited applicability.
Yes. So I believe people are still digesting the information that has been presented. And I would like to thank you so much, Dr. Nachiketa, for this comprehensive information that you have given. It is not easy, and I can understand that. And it will take time for everyone to kind of digest what you have uh, taught us today. Thank you so much. Over to you, Dr. Nair.
Yeah, thank you, Dr. Ashutosh. Thank you, Dr. Nachiketa. That was a lot of information in a short period of time, but it was very beautifully you have, connected neurodevelopmental and neurodegenerative diseases and how we find similar findings in autism, schizophrenia, and possibly in even some of the neurodegenerative disorders. So that was indeed very interesting that, there is evidence which shows that similar kind of pathologies are happening in over a spectrum of disorders. So thank you for giving us a peek into what microglia do and how their dysfunction can impact the working of the brain in many myriad ways and in several disorders. Thank you, Dr. Ashutosh Shah, for chairing this session. And thank you, audience, for being here with us. And let's look forward to the next meeting on 24th. Thank you all. With that, we conclude this
Agreed.
session. Thank you.